Hi, my name is Tori and I am a doctor of physical therapy who specializes in pelvic floor dysfunction. Part of pelvic floor dysfunction includes bowel dysfunction, and that can look like a couple of different things on the spectrum. Think really difficult to treat constipation, or the other end of the spectrum, which would be leaking feces, leaking poop. We call that fecal incontinence. Or even fecal urgency, where someone is feeling like they need to poop like 5 to 7 times a day. They try to poop, but they end up only pooping once, if at all. Needless to say, I see both women and men that have bowel dysfunction and have undergone anorectal manometry testing. However, a lot of these humans have either a small or no true understanding of how that testing works and a vague understanding of why that testing was done in the first place. I looked on the internet and I couldn't find an easy to understand description of anorectal manometry, so I decided to make it myself. In order to understand anorectal manometry testing, why it would be indicated and how it works, it's really important that you understand the digestive system. So I am going to break down the digestive system as best that I can. Let's start with an overview of what would happen if we followed a piece of food all the way from when it enters your mouth to when it exits into the world through your anus. So you would put that piece of food in your mouth, chew it up, and then you would swallow it and it would go down your esophagus. Your esophagus would eventually lead to your stomach, which is actually located kind of right under your left rib cage, right here. Now, this food would stay in your stomach for anywhere between 2 to 4 hours, getting mixed and chopped, and eventually when your small intestines are ready, it would enter into your small intestines. Now, if your stomach is kind of under that left rib cage area, your small intestines, if my belly button's right here, kind of live towards the front of your abdomen, around your belly button. This piece of food would stay in your small intestines for between 4 to 6 hours. This is where the majority of true digestion and absorption of nutrients occurs. After that piece of food was done in your small intestines, it would enter into your large intestines. If your small intestines live around your belly button, then your large intestines travel from your right lower quadrant up, kind of right under your diaphragm, and then down. Your large intestines eventually empty into your rectum, and then your rectum empties into your anus, and then that feces enters into the world. Now, transit time from large intestines to rectum can take anywhere between 24 to 72 hours, and your large intestines are kind of amazing because they take anywhere between 1 liter and 1.5 liters of thick liquid in per day, and then only about 100 to 150 milliliters ends up in your rectum as waste or feces or poop. Now, you can further break down your digestive system into an upper tract and a lower tract. Anorectal manometry is going to focus on the lower portion of your GI system. The upper portion is going to be your mouth, your esophagus, your stomach, and your small intestines, where the lower portion is going to be your large intestines, your rectum, and your anus. So with that in mind, I need to make sure that you understand your lower digestive tract really, really well. So let's start by reviewing the anatomy of the lower digestive tract a little bit more in-depthly. Your large intestine, or your colon, is going to start, as we said earlier, kind of in that right lower quadrant area, and your colon or your large intestine has a couple of different parts. It's going to have your ascending colon, your transverse colon, and your descending colon. Now, your descending colon and the rest of your large intestine lives pretty close to the front of your abdomen until your descending colon takes a sharp turn backwards towards your spine. Now, you have your spine, and then you have a bone that kind of lives between your spine and your tailbone. It's called your sacrum. Your descending colon makes that sharp turn towards your spine and then follows the curvature of your sacrum down towards your tailbone. To get super technical about it, your large intestine actually becomes your rectum about halfway between your sacrum. For those that are curious, your rectum matches up with around S3 through S5. And then your rectum becomes your anal canal right at the start of your tailbone. I feel like the sun is in my eyes. I'm gonna move my camera a little bit. Then, if we deep dive a little bit more into the anatomy of your anus and your rectum, your actual anal canal is only about 3 to 6 centimeters long, which is essentially like 1 to 2 inches. And then above your anal canal, your rectum is more like 12 centimeters long, which is only about 4 to 5 inches. Now, there are some important sphincters and muscles to know about in this area. If this is your anus, at the very bottom of your anus, you have a sphincter. It's called your external anal sphincter, and that is under voluntary control. That's skeletal muscle, just like your biceps or any other muscle that you have voluntary control over. Now, more towards the top of your anal canal, right before your rectum, you have a different sphincter called your internal anal sphincter. This sphincter is smooth muscle. You don't have any control over it. Your intestines are smooth muscle. Your stomach is smooth muscle. You don't have control over these muscles. They're involuntary. So within the anal canal, we have the external anal sphincter that you can control. We have the internal anal sphincter living above it. You can't control it. And then above the internal anal sphincter that differentiates the anus and the rectum is your pelvic floor, my favorite group of muscles. There is a specific pelvic floor muscle that kind of slings around your rectum, and it can affect the angle that feces has to travel from your rectum into your anus. So follow me here. If this is your anus and this is your rectum, this pelvic floor muscle can change the angle that poop has to travel to go into the rectum and out through the anus. We call that your anorectal angle. I feel like the sun is just following me all around right now. Super fun fact about your anus and your rectum. There is a line in your anal canal about halfway up, so maybe like an inch or so in, where the tissues communicate differently with your brain. What I mean when I say that is below the line, so the first like inch or so in the anal canal, your brain and those tissues can communicate about pain, touch, and temperature. Which is why if you have external hemorrhoids, if you have hemorrhoids that you can see, they bleed and they hurt. Above that line, the only communication that your tissues have with your brain is stretch, which is why if you have internal hemorrhoids, they'll bleed, but they won't hurt because those tissues can't communicate pain with your brain, only stretch. Fascinating. So now that you have an idea of how your digestive system works and where it lives, let's talk about how you defecate or how you poop. When food enters your stomach, there is a reflex that's initiated. That reflex is called your gastrocolic reflex, and what it does is it initiates peristalsis in your large intestines. So think about a snake eating a mouse, that like rhythmic contraction of the snake's body as it digests the mouse. That's what peristalsis looks like in your intestines. Except with your intestines, that peristalsis or those rhythmic contractions are pushing stool towards your rectum. So food enters your stomach, the gastrocolic reflex happens, your large intestines rhythmically contract or undergo peristalsis, and food is propelled towards your rectum. Technically it's stool, not food at this point, but you get what I mean. When this stool enters the rectum, your rectum starts to stretch, and as we talked about earlier, that's the only way that it communicates with your brain. So your rectum starts to stretch, and after it reaches a certain volume, you have the urge to defecate, or the urge to poop. So now you know that you have something in your rectum, you know that it's time to poop. Then a different reflex takes over. This reflex is called your sampling reflex. So follow me here. Remember the different sphincters in your anus? Your external anal sphincter, the one that lives really, really close to the opening of your anus, contracts, Your internal anal sphincter that lives above it, the one that you don't have any control over, the smooth muscle sphincter, relaxes, and about 30 or so milliliters of fecal matter, of your poop, of your stool, enters into that space. And this is a way for your body to decide, is this gas? Is this liquid? Am I gonna have diarrhea? Or is this formed stool? Am I gonna poop regularly? Think about your mouth. If something was coming up the other end, you know when you're gonna burp. You know when you're gonna vomit. You know if that vomit's gonna be liquid or if that's gonna be more formed. The exact same thing is happening, but on the other end of your digestive tract. So let's review that whole process one more time. Food enters your stomach. The gastrocolic reflex happens. Your large intestines start to rhythmically contract and propel stool towards your rectum. Your rectum starts to stretch. You become aware that there's something there. The sampling reflex happens. The internal anal sphincter that you can't control relaxes. The external anal sphincter that you can control contracts. Your body samples what's going on and decides, is this liquid, is this gas, or is this solid? And then you know you need to poop and you know what's going on. Now, you probably know from your own life experiences that you don't always have to immediately run to the bathroom to poop the second that you realize that there's something there to evacuate. That's a different reflex. You can override your intrinsic urge to poop with something called the recto-anal inhibitory reflex that healthcare providers will sometimes call RAIR, R-A-I-R. Essentially, all that is if you voluntarily contract that external anal sphincter that lives at the bottom of your anal canal for like 45 seconds to a minute, it'll cause that internal anal sphincter that you don't have control of to contract. That sampling of your feces or poop will come back up into the rectum, and the urge to defecate or the urge to poop will subside, and you can delay it until you decide it's appropriate. Other super fun fact to inject here, that's the case usually with harder, more formed stools. If you have diarrhea, you are not gonna have a lot of time to get to the bathroom. That is a normal response, urgency, and an inability to hold back diarrhea very long, really at all. If, on the other hand, you decide that you do want to poop, you have the urge and you're like, yeah, now's an appropriate time, I can poop, your external anal sphincter will contract until you find the appropriate location to poop. Remember that anorectal angle that I was talking about earlier? You want that angle to be as close to a straight line as you can get it, because you want feces to be able to travel straight down rectum through anus instead of making jagged turns. That makes it a little bit more difficult for you. So you've held your external anal sphincter until you find the appropriate place to defecate, and then you're going to sit down or squat potentially, which is gonna increase that angle a little bit more. And then ideally that pelvic floor muscle that we alluded to earlier is gonna relax, which is going to increase that angle just a little bit more. And then that external anal sphincter that lives at the bottom of your anus is going to relax, and you'll begin to defecate. Now, you may need to use a little bit of a gentle push or bearing down in order to initiate defecation or initiate pooping. It depends on how long you've held back your urge. If you acted on the urge within a couple of minutes, you really shouldn't have to push at all. If you delayed the urge for a while, a little bit of increased intra-abdominal pressure or that pushing, kind of gentle pushing, is going to be needed to begin the process of pooping, but you shouldn't ever have to maintain that push or strain. So if you are pooping like this, we should talk about it. You shouldn't be doing that. So your GI system is fascinating. Your lower GI system is probably a little bit more involved than you expected. At least when I first learned about it, I thought it was more involved than I expected. But having a really good understanding of the GI system, and especially the lower portion of it, makes anorectal manometry testing make so much more sense. The sun is still following me around. Okay, so let's talk about anorectal manometry testing, how it works, and what it looks at. Anorectal manometry uses a catheter with a balloon on the end inserted rectally, and it looks at a couple of different functions. One of the things that it's going to look at is the function of those sphincters that we talked about, so the function of your external anal sphincter and the function of your internal anal sphincter. And the way that it does this is looking at the pressure in your anal canal. So there are established norms for the resting pressure or the resting tone in your anal canal, and that resting pressure is indicative or correlates with how well your internal anal sphincter is functioning. Now, if you voluntarily squeeze or activate your external anal sphincter, which is under your voluntary control, that's going to be indicative of how well your external anal sphincter is working. And I think that the norm is usually 150% or so of the resting pressure of your anal canal. Anorectal manometry is also going to look at your reflexes. We talked earlier about the recto-anal inhibitory reflex, aka can you hold your external anal sphincter for long enough to delay the urge to defecate or not? If you can't, is that why you're leaking feces? Maybe. There's another reflex called your recto-anal contractile reflex, and this is essentially when there is a big surprise increase in intra-abdominal pressure, which is just a fancy way of saying like a cough or a sneeze. Do your muscles properly contract in order to hold back any sort of stool that might be in the rectum so that you don't leak? If this reflex isn't working, could that be why you're leaking feces? Maybe. Anorectal manometry is also going to look at your rectal sensation. So remember, we've talked about a couple times that the only way that your rectum and your brain, above that line in your anus, but essentially the only way that your rectum and your brain communicate is via stretch. So there are established norms for the amount of volume that can fill your rectum until you first have a sensation that something's there, first feel the urge to poop, and then maximum tolerance, you can't tolerate any more volume in your rectum. That first sensation is usually around like 20 to 35 milliliters. That urge to defecate, that urge to poop is usually around 100 to 150 milliliters. And that maximum tolerance, like I can't stand any more stretch now, is usually between 200 to 300 milliliters. And inadvertently, that maximum tolerance is also testing rectal tissue compliance, which is just a fancy way of saying how well do your rectal tissues move. Do your rectal tissues really not move very well at all, and that's why you feel like you have to poop all the time, even though you don't have enough poop in your rectum to actually be indicative of a true bowel movement? Or on the other side of that coin, are your rectal tissues moving so much that it takes more stretch than usual for you to be aware that you have to defecate, and that's why you're constipated? Maybe. And finally, anorectal manometry is going to look at your muscles and see what are they doing when you poop, aka what are they doing when you expel a water-filled balloon. Like we talked about, ideally your pelvic floor would relax to help that anorectal angle be as close to a straight line as possible. Your external anal sphincter that lives right at the opening of your anal canal would relax, and you might need a little bit of intra-abdominal pressure to get things going. Now, what if your muscles accidentally contract when they should be relaxing? Could that cause constipation? Totally. Is anorectal manometry a bizarre test? For sure, but if you break it down, it makes a lot of sense. And there's a lot of really valuable information that you could potentially glean from having the testing done. Now, if you had anorectal manometry testing done, you might benefit from pelvic physical therapy. If you're leaking feces because your external anal sphincter is weak, we can train that. If your pelvic floor muscles contract instead of relax when you're trying to have a bowel movement and that's why you're constipated, we can train that. If the reason that you feel like you have to defecate all the time is because your rectal tissues are hypersensitive and you have the urge to have a bowel movement when there's only 50 milliliters of volume there instead of 150, we can retrain that. What I will say is that colorectal is a subspecialty within pelvic floor, so if you do decide to pursue pelvic floor therapy, which I hope you do, make sure that you talk to the office that you decide to go to and ask if there's a therapist that deals more with colorectal issues for you. Check out the description below for a link to a directory to find a pelvic rehab provider near you so you can get evaluated and see if it's the right call for you and what's going on with your bowels. Thank you so much for watching. I did write an article about anorectal manometry, so if you want to have a text version of all the things that I've said throughout this video, check the description below. There should be a link there. Feel free to comment regarding this topic or any other topics surrounding pelvic dysfunction that you'd like to see. I hope that you have a wonderful rest of your day, and thanks again for watching. Bye!